Good evening, everybody. I welcome you to the next session, the RADV 2025 Resident Case Competition. So this is one of the very exciting sessions in this conference. I would encourage all the presenters to, when you come on stage, please present yourself, say your name, say where you're studying or where you're working, because we will be going very quickly. Also, each one has 6 minutes, and the judges will be looking at several criteria for the scoring, the uniqueness of the case, the ability to provide good differential diagnostic list, the ability to present confidently, the ability to answer questions, and adherence to time. So these 5 factors they will be looking at. So best of luck, everybody. And I would like to invite our first presenter, Dr. Abir El-Mamari.
Assalamu alaikum. Can I start now? Okay. Assalamu alaikum. I am Dr. Abir El-Mamari from General Foundation Program under OMSP from Oman. I am working in Rostaqbul Clinic. So today I'm presenting unusual manifestation of neurofibromatosis type 1, a case report of vulval mass. So starting with the neurofibromatosis type 1, it's an autosomal inheritance disorder that affecting the skin and nervous system. Usually for diagnosis, they used to diagnose the neurofibromatosis type 1 by clinical features, genetic testing, and also imaging. The prevalence of neurofibromatosis type 1 is 1 in 3,500 individuals. And the plexiform neurofibromas is a rare tumor that can affecting 5 to 15% of neurofibromatosis type 1 and causing a significant management challenges. One of the clinical features of neurofibromatosis type 1 is caveolate spots, as you see here in the picture. And also, the description of plexiform neurofibromas as a bag of worms. And here, an Indian boy having a plexiform neurofibromas, unfortunately, on his face. Returning back to my case, it's a 16-year-old girl with neurofibromatosis type 1 presenting with a rare plexiform neurofibromas on labia majora. The symptoms started with progressive swelling, discomfort, and difficulty on walking. On the examination, she has multiple skin manifestations like freckles, caffeolate spots, and also neurofibromas. They did an MRI for her, showing a labial mass from measuring around 7 into 7 into 1 centimeter cube. The continuation of the mass was till the adductor muscles. So the initial treatment was a hemivalvectomy in 2017. Then the recurrence happened in 2019 and in 2022. On the biopsy showing a plexiform pattern with nerval bundle that involving spinal cells. So plexiform neurofibromas is a benign but infiltrative with a high recurrence rate. The malignancy risk is from 8 to 15% of plexiform neurofibromas that can transform into neurofibrosarcomas. And neurofibromatosis type 1 is a mutation in NF1 gene on chromosome 17. And as I said, the diagnosis based on clinical criteria, genetic testing, and imaging. So the regular monitoring is essential to detection for the complication. Also, the involvement of multidisciplinary team is help neurofibromatosis cases with plexiform neurofibromas. Psychological support also is important in improving the patient quality of life. So in conclusion, this case is highlight the complexity of managing the rare plexiform neurofibromas in neurofibromatosis type 1. Emphasize the need of multidisciplinary team and also focus in improving the future efforts in improving the surgical outcome. They have used some medical treatment to shrink the tumor, but they failed. Actually, they tried to use JAK inhibitors, but they failed to shrink the tumor. But they used MEK inhibitor to shrink also shrinking the tumor, but they shrink it about 50% only. Yeah, thank you.
Any questions? We still have a minute from the jury.
The sites, actually. The site is very rare, yeah. It's the same, actually, but the only difference is the sites, yeah. Yeah. What?
What is the term which is used to describe this condition, a plexiform neurofibroma? Is there any catchy term used to describe this?
No, actually.
Is it the bag of worms?
I mean that description, bag of worms, yeah.
Okay, thank you very much.
Thank you.
Our next speaker is Dr. Ali Douri. His title is Dermatomyositis with False Positive Dengue Serology, a Diagnostic Challenge. Very good.
Hi, good evening, everyone. I'm not going to confuse you. I think everything is there within the title, but I think it's quite an interesting case, and I'm going to tell it in a little bit of a story form. So I was sleeping at 3 a.m. and I got a call from the emergency department telling me that we have a case of dengue fever with a rash and we would like some dermatological review for it. By the time I attended the emergency, I saw a 24-year-old Syrian female who has an itchy rash that started on the face and spread to involve the trunk and extremities, and this has been ongoing since the past 3 weeks. They had already, during that time, every time we get some sort of rash, we do dengue serology for them because it became endemic in the UAE, and her dengue IgM had been positive. However, it did not make sense that it's been ongoing for the past 3 weeks. This is her first episode of the rash, and I had asked her about what has been associated with it. She said that it's not associated with fever. She does have arthralgia. She does have muscle weakness. And then upon taking further history, she told me that she was on medication. This is how it started off, actually. She told me that she's on 3 medications. She's on methylprednisolone, she's on sulfasalazine, and she's on hydroxychloroquine. I asked her why. She said that she had developed joint pain and joint swelling 1 month earlier, and she was diagnosed as seronegative arthritis in Syria, and she was started on this just because she had rheumatoid factor negative. So this is her past medical history with what I just said about the medication. What about her family history? She said that she had no significant family history. On examination, we saw some erythematous edematous plaques on the chest and back. Some of the lesions were maculopapular, particularly on the outer arms and on the outer legs, and some areas that had some sparing. And I just want to point you out to that picture on the left-hand side of the fingers. This is what actually gave me a clue of this could possibly not be dengue. It's not just the duration, it's just that the knuckles are involved and the rest of the fingers are not. Also, you can see that the rash is edematous on the abdomen, and this is her outer arm where she has that sort of edematous and maculopapular rash. I came in with a differential diagnosis, so since her dengue serology is positive, we said that could be dengue fever. We said that it might be drug eruption because of sulfasalazine, but I also thought of connective tissue disease because of the fact that her knuckles were involved. So I checked her labs. Her NS1 was not positive as her NS1-AG, but during that time, because she's not Emirati, the cheapest thing that I could do for her was actually doing a skin biopsy. So we did that, and we sent it to Dr. Reem Bahtemi at the time, who was very generous enough to help us with it, and it showed that interface dermatitis with mucin deposition was there. She has done an Elsham blue stain. It showed that superficial and deep mucin deposition, and perivascular and periadnexal infiltrate along with it. That's when we were able to get some help financially and do the ANA. ANA was positive for her. This is what we started her on, and then we sent her to the rheumatology lab for further investigation. During that time, her CPK also appeared to be elevated. She had JO1 positivity as well. And we had reached the final diagnosis of dermatomyositis. Now, why is this very important for us? Yes, we can look at the dermatomyositis. Sometimes they come in and they tell you that the diagnosis is already there. I think that happened with all the residents in my department, that the diagnosis is there. We just want dermatology review and to be on board. So we need to really examine the patient, and we really need to check whether or not this is the correct diagnosis, despite there is a positive serology. During that time in April 2024, I think the case came in May, we experienced the heaviest rain in Dubai. My car was a collateral damage, unfortunately, during that rain, and there was a surge of dengue fever in the UAE. Usually with dengue fever, the skin rash develops 24 to 48 hours after the spike of fever and then on the last day of the fever. So it did not make sense. Having dengue fever positive, the IgM positivity means that she had dengue fever in the last 5 days. So again, it did not make sense that it's been going on for 3 weeks and the IgG is still negative. The viremia may trigger immune complex formation in patients who are pre-diagnosed or predisposed to having some sort of rheumatological diseases, particularly lupus erythematosus, which is where I found most of the cases focusing on. We all know that with rheumatological diseases, we can get false positivities due to the immune complexes that happen in the blood. Now, I've seen that multiple cases of the falsely diagnosed dengue, or dengue actually, they developed dengue fever, had progressed to becoming lupus erythematosus in the predisposed patient. Some patient developed lupus nephritis because they were treating them as dengue and they did not diagnose the lupus because it kept on going for a very long time. And in a known case of SLE, dengue fever may mimic the case of active lupus. So we always need to be checking and rechecking our diagnosis. Now, the thing about dengue IgM, this is the one, like NS1AG is actually very specific, but dengue IgM is not very specific. And this is one of the things that can be a false positive in connective tissue diseases. So we really need to be checking and rechecking our diagnosis when we get a dengue IgM. Does it fit the clinical picture or does it not fit the clinical picture? And whether or not we should be following up this patient. Some case report of false dengue positive in SLE patient led to misdiagnosis and having multiple comorbids. So thank you very much. Always recheck your diagnosis. Thanks a lot.
Thank you. Right on time. Any questions from the jury? I think she had some classic signs on the clinical. I mean, the Gottron's papule, anything on the face?
So what was interesting about this case is when we did the examination for her, the neck was spared, the face was affected. There was no heliotrope rash around the eyes, okay? But I did see the holster sign. I did see that the outer arms were also affected. So yes, she did have clinical signs that are there, but it was very confusing case in terms of trying to figure out what kind of rash it is, because it wasn't like the fingers, there were no papules. It was just erythematous and edematous at that time. And at the same time, she didn't give you that, I can't comb my hair, I can't get out from bed. She just says that I'm like just really tired and, I have mild joint pain.
Okay. Nice case. Thank you, Dr. Ali. Thank you. Okay, it's my pleasure to invite Dr. Sheikha El-Kadbi.
Thanks a lot.
What is hidden is even greater. Cannot wait.
Assalamu alaikum. So I want to give a special thanks for Dr. Reem for this case as we diagnosed it together with her. What's hidden is even greater. So our patient is 63 years old man with a single lesion on the chest since 5 months. It started as an asymptomatic pimple on the chest, progressed and become tender, red, ulcerated, to discharge yellowish clear fluid. Past medical history is unremarkable. On examination, it was single eroded nodules with erythematous base measuring 1 centimeter on the chest. Dermoscopy findings was yellow lobules, white yellow lobules, and our differentials was PCC, keratoacanthoma, adnexal tumors from the clinical and the dermoscopy picture. Hence, we took an excisional biopsy, and this shows a low power of an H&D stain of cystic mass and showed a well-formed organoid structure. On a higher power, we can see the several layers of germinative cells and maturing into sepocytes. EMA stain were positive also, and by that, we reached to a final diagnosis of cystic sebaceous adenoma. So the excision was with clear markings, healed well and with minimal scarring. So patient is happy, doctor is happy, end of story. Or is it? For that, we took one step further and we ordered 2 molecules. Any ideas? So we ordered MSH2 and MLH1, which in turn showed a loss of MSH2 in that lesion. By that, we reached to the hidden diagnosis of Muir-Torre syndrome. As a discussion, adnexal neoplasms are often benign. However, they can be a marker for underlying genodermatosis with increased risk of malignancy. Muir-Torre syndrome is an autosomal dominant disorder with mutation in DNA mismatched repair gene linked to MSH2, MLH1, MSH6 mutations, and mainly associated with skin findings and internal malignancies. The main skin findings is adnexal tumors and keratoacanthomas. Adnexal tumors including sebaceous adenoma, which is the most common, and then sebaceous carcinoma. There is a lot of cutaneous findings that is linked to genetic diseases that could be a sign of internal malignancies, such as trichotillomatosis in Cowden disease or syndrome linked to breast, thyroid, GI. Pilomatrichomas in Gardner syndrome linked also to GI, thyroid, and osteomas. And the list goes on. Now, coming back to our syndrome, sebaceous neoplasms can present prior, with, or after the diagnosis of visceral malignancies and can appear decades before or after the diagnosis of the visceral malignancies. But keep in mind, multiple lesions in atypical location other than the head and neck indicates further evaluation of Muir-Torre syndrome. Now, there is a recent screening recommendation updates for the Muir-Torre syndrome screening, and it involved the annually skin examination, colonoscopy, when to do upper endoscopy, when to do endometrial ovarian cancer screening, and cytogenic examination. Take-home message: a single skin tumor can be a marker of a hidden danger lurking inside the body. Our case highlights a very rare case of cystic sebaceous adenoma, which is part of Muir-Torre syndrome. Suspect from histological pictures, markers such as MSH2, MLH1, and also genetic testing is helpful, both on cancer surveillance and multidisciplinary approach. Thank you.
Any questions from the jury?
I saw that you did a dermoscopy, right?
Yeah.
Okay. Did you suspect that it was a benign lesion rather
It's
than a
something
malignant?
Yeah, it's something with adnexal tumors, we
Yeah,
can say.
but the difference with, sebaceous carcinoma? Because on dermoscopy, of course. Because I saw that it was very regular in terms of vascularity.
Yeah, that
and
wasn't.
there were the globules corresponding to the lobules. Yeah.
Maybe I can say it's well-oriented.
Yeah. Usually when you have, a more polymorphic vascular pattern, you have to think about, sebaceous carcinoma.
Exactly.
And in sebaceous carcinoma, you don't have the globules, but there is a little bit of yellow. So the vascularity is the main differentiation point.
Yeah.
Okay.
Thank you.
Great.
Did the patient have any family history?
No. But
So did you
they have,
provide a family tree? I mean, going back when you...
no, from our side, we advise for screening for him and the family.
So any follow-up on that? Not yet.
No.
Thank you. Thank you. This is a nice case. Our next speaker is Dr. Reem El-Husseini, a rare combination insights from a unique patient.
Assalamu alaikum. I am Reem. I am a dermatology resident at Rashid Hospital. Today I'm presenting a rare combination insights from a unique patient. So during my on-call shift, I received a call from the neonatal ICU doctor requesting an urgent skin biopsy for one-day-old Omani male newborn was born with areas of skin peeling and erosions, and the erosions and the skin peeling were specifically affecting the face, buttocks, and the scalp. There was no other skin lesions like blisters or cellophane membrane was noted at birth prior to the peeling, and review of systems were unremarkable. Birth history was also unremarkable. The baby was placed in an incubator. He was vitally stable. The skin was dry, mildly erythematous, shiny, with superficial discoloration affecting many parts of the body. And also, as you can see in the photo, the buttocks was covered with diffuse, intense erythema and erosions. Upon examining the patient, I noticed that the patient had bilateral cleft lip and palate. Not only that, he was unable to open his eyes due to partial fusion of the upper and the lower eyelids, and there was no eyelashes. The hair was normal, but the scalp showed areas of erosions. In the nails examination, he had dystrophic nails with certain digits involving absence of nails, as you can see in the photo. The other systemic examinations were unremarkable. Our differential diagnosis included epidermolysis bullosa and ichthyosis. So we did the skin biopsy. It was non-specific and with a remarkable epidermis, and the dermis was showing perivascular lymphocytic infiltration in the dermis. So here we thought that there might be something else. We sat down with the family, and surprisingly, the father revealed that the elder sibling, who is 1 year old, was born with the same presentation, with the cleft lip and the palate, and even the father himself, he was born with the cleft lip and palate, which was repaired surgically, and he showed me also the abnormal features. So here we suspected that there might be something else. So we referred the patient to the pediatric genetics, in which the rapid whole genome sequencing was done, and the results came out as P63 mutation. So we connected the puzzle, and we finally diagnosed the patient with ankyloblepharon ectodermal defects cleft lip palate syndrome. The management was multidisciplinary approach. The dermatology treatment focused on symptomatic care, and the wound care was coordinated with the pediatric plastic surgery team, in which the Mepilix was used to cover the erosions, and frequent emollients were also given. Now, the parents were also provided with genetic counseling, so they received information about the P63-related disorders, including the clinical features, the prognosis, and the potential complications. And also, most importantly, they also received information about the prenatal diagnostic options for future family planning. So currently, our patient, he is 5 months of age, and he is regularly following up with us in dermatology, and he's following with the other specialties as well. And however, during the 5 months, the patient was admitted twice at the hospital for recurrent scalp infections, treated with appropriate antibiotics. And however, we are now closely following him up to avoid any recurrence of scalp infections and other dermatological concerns. So ankyloblepharon ectodermal defects cleft lip palate syndrome. It is a rare genetic disorder, also known as Haywell syndrome and Raab-Hodgkin. It is a rare autosomal dominant disorder with an unknown prevalence, and it is due to missense mutations in the SAM domain of the P63 protein. As we know, P63 protein is very important, not only in the development and maintenance of the skin, but it is also important in the other ectodermal tissues, as well as the orofacial structures and limbs. So the clinical features are usually evident at birth, and as you can see in this slide, it does not affect only the skin, it affects the other orofacial structures and the ectodermal tissues. So the diagnosis is mainly by the clinical findings plus the genetic studies. The management is multidisciplinary approach, so for the skin erosions, particularly on the scalp, they are difficult to treat and are prone to infections. So we usually manage the erosions with gentle wound care and antimicrobial soaks. Overall, the prognosis of AAC is good, with most having normal life expectancy with proper long-term follow-up. So our take hospital message, AEC syndrome, is a rare genetic disorder requiring thorough clinical evaluation and genetic testing for accurate diagnosis. Early diagnosis and intervention are crucial for managing symptoms and improving quality of life, and genetic counseling is essential for affected families to understand the risk and make informed decisions about the future pregnancies. Finally, I would like to thank our government for implementing the mandatory genetic testing within the premarital screening starting from January 2025. Thank you.
Thank you. Very nice case, Reem. Any questions from the jury?
It's very common that genetic testing and many of these things are not present everywhere. So my question would be, if you did not have access to genetic testing, what would your approach have been?
The approach will be we will focus more on the clinical presentation plus the family history. So I think we can diagnose it based on the clinical features plus the family history, even without the genetic testing.
That's good.
Thank you. Thank you.
In the future pregnancies.
Okay, so now when the family history is known, we can simply prevent it by doing the amniocentesis or the chorionic villus testing during the pregnancy.
But anything like before the pregnancy?
I'm not sure.
IVF? Yes.
Okay. Thank you.
Thank you. Our next speaker is Dr. Fida Anjoum, Assessment of Quality of Life, Mental Well-Being, and Disease Activity in Patients with Chronic Urticaria, a cross-sectional observational study.
Assalamu alaikum. Good evening. I'm Dr. Fida Anjoum from Yanapaya Medical College, Mangalore, India. The title of my study is Assessment of Quality of Life, Mental Well-Being, and Disease Activity in Patients with Chronic Urticaria, a cross-sectional observational study. Introduction. Chronic urticaria is a debilitating dermatological condition characterized by transient pruritic wheals and/or angioedema lasting for more than 6 weeks. It affects beyond the physical symptoms, severely impacting the quality of life and mental health. The growing prevalence in India highlights the need for targeted management strategies. The objectives of the study were to assess the quality of life in chronic urticaria patients using the Chronic Urticaria Quality of Life Questionnaire, to evaluate the anxiety and depression using the Hospital Anxiety Depression Scale, to measure the chronic urticaria disease activity using the Urticaria Activity Score, to correlate the quality of life and mental well-being with disease activity. It was a cross-sectional observational study which we carried out on 67 chronic urticaria patients. It was conducted at a South Indian Tertiary Care Center from September 2023 to May 2024. The ethical clearance was obtained. Assessment of quality of life with Chronic Urticaria Quality of Life Questionnaire and mental health with Hospital Anxiety and Depression Scale was done. And the disease activity was evaluated using the Urticaria Activity Score, UAS-7. Then the correlations between the quality of life, mental health, and disease activity was analyzed. Results and discussion. The following table gives the demographic of the patients. There were 67 patients, and the mean age was 35.58 plus or minus 13.03 years, and mean duration was 27.16 plus or minus 47.44 months. There were 34.3% of males and 65.7% of females. The chronic urticaria quality of life scores had a mean value of 72.36 plus or minus 20.64, which indicates substantial impact on the quality of life. Females reported higher scores compared to males, which reflects a greater emotional burden among them. The quality of life chronic urticaria scores, the questionnaire had 6 domains, out of which the domain 4 and 5, that is, the sleep problems and limitation of daily activities, were impacted the most. The depression and anxiety scores, abnormal levels of anxiety were there on 29.9% of the patients, and abnormal levels of depression, 22.4% of the patients had. Anxiety significantly correlated with the disease activity. There were strong correlation between the chronic urticaria quality of life scores and anxiety as well as depression, but with anxiety it was highly significant. Urticaria activity scores, the UAS-7 scores had a mean value of 23.49 plus or minus 11.96. Males had higher scores compared to females, which indicates more severe physical symptoms in males compared to females. There were gender differences seen. Females had greater emotional impact as they had higher chronic urticaria quality of life scores, and males had more severe physical symptoms as they had higher urticaria activity scores. There were no significant correlation between the chronic urticaria quality of life scores and the urticaria activity scores. The quality of life is influenced more by the psychological and social factors than the symptom severity. This graph shows the correlations. There are disease control challenges. Many patients reported inadequate disease control despite systemic medication availability. It suggests a gap in treatment adherence or suboptimal therapeutic regimens. The sleep disturbances are critical, but they are often overlooked. Improving the sleep quality via cognitive behavioral therapy or pharmacological interventions could enhance the quality of life. Conclusion: the chronic urticaria impacts the physical and emotional and mental well-being. The recommendations from this study are holistic management, that is to integrate the psychological and dermatological care and to address the anxiety, depression, and sleep disturbances. Gender-specific strategies, that is tailor care to meet the emotional and physical needs of both males and females. And patient-centered approach, that is to emphasize the treatment adherence and access, especially in culturally diverse populations like India. Future directions are to conduct larger multicentric studies to validate these findings and to explore the regional and cultural variations in the chronic urticaria management. These are my references. Thank you.
Any predisposing factors to the chronic urticaria, like food or?
No, mainly treatment adherence. Like most of the patients which presented to us, they were not taking the medications properly. They were not sticking on to the treatment regimen.
Okay. How many were confirmed by biopsy? Were any biopsies done for these cases?
No, we had not performed biopsy. It was based on the clinical features. We diagnosed the chronic urticaria. Dermographism we had done.
Okay. Any questions from the?
Very interesting. But first question will be just for an interesting dialogue. Chronic urticaria and chronic spontaneous urticaria are very much in focus right now because of development of a lot of drugs which are in the pipeline. Validated severity indices are being discussed all over the world. So what do you think is the most critical point? Why would you do a study like this when you already have a DLQI or a chronic urticaria quality of life score already available which are validated?
Yes.
In what way does your study differentiate it from a chronic urticaria quality of life or a DLQI?
Okay, especially in my study, the urticaria activity score US7 was taken, which makes the patient itself responsible. Like we had given the patient itself the performa to fill from their home for 7 days, and they got back after 7 days via WhatsApp. So they were responsible for their own. So they will feel like if they adhere to the treatment, it will reduce. So it makes them responsible more. So even the chronic urticaria quality of life, which showed there were impact, they will feel responsible, like they are itself ticking the questionnaire, and from home they are only following it back. So they will feel if they adhere to the treatment, there will be a difference. So that was found. Like after 7 days, the scores were reducing. Usually I found that the treatment adherence was not there. So if they stick on to the treatment, it is making them only understand that it is reducing. And there is no studies which has correlated these three. That is the quality of life, the anxiety and depression, and the disease activity. So these correlations, we have found the anxiety and depression, it correlates with the disease activity. So by making them realize that if they are responsible, if they adhere to the treatment, the disease will decrease. So by that way.
Thank you.
Thank you.
I'd like to invite Dr. Khalifa Al-Meheri, a mysterious acral lesion.
Assalamu alaikum. So my name is Khalifa Al-Meheri. I'm dermatology resident from Rashid Hospital. So the title for my presentation today is a mysterious acral lesion. So a 43 years old Sudanese gentleman presented in our clinic with multiple lesions on the right foot of 3 years duration. It gradually increased in size and shape over time. So it began as a single papule, and it increased over time. It was associated with mild pain while standing for a long time. So a quick history, the patient is a known case of diabetes mellitus type 2 and hypertension as well. He had one incidence of cellulitis 3 months ago after soaking his right foot in warm water. It was treated with IV antibiotic. Patient is currently on antidiabetics. He's unmarried. He's working as security guard. He denied any pets contact, denied recent travel history, no history of trauma, allergies, other dermatological condition, and no family history of similar presentation. So generally the patient is stable, he's alert, obese, but he could mobilize. So for the dermatological examination, as we can see, a 10 by 6 centimeter lesion with multiple hyperkeratotic verrucous flesh-colored papules and plaques. There is a cobblestone-like pattern, as we can see, some crusting, fissuring as well. By palpation, it was rough inconsistency. Generally, the patient systemic examination was unremarkable. Our differentials after the clinical inspection is verrucous vulgaris, tuberculosis verrucosa cutis, SCC, chromoblastomycosis, eccrine poroma, and eccrine syringofibroadenoma. So the imaging, we did an X-ray of the right ankle. It wasn't significant. Labs was pointing to diabetes mellitus type 2. So we took 2 skin punch biopsies of the lesion. Initially, it was fibrous in appearance and it was consistent with viral wart. Few cryotherapy sessions were done also, but the patient unfortunately was not improving. So we decided to take 2 more skin biopsies from different area of the lesion, and here is the result. So we can see here it's an interesting figure, honestly. The epidermis show parakeratosis. The epidermis is hyperplastic. We can see this thin interconnected anastomosing strands originating from the epidermis and diving deep into the dermis. It's embracing a fibrovascular stroma that is rich with inflammatory infiltrate. And this is also a significant feature, epithelial strands with ductal differentiation. And here we come eventually to the diagnosis of eccrine syringofibroadenoma. So the patient was initially treated with topicals and emollients under occlusion. He was advised to avoid tight shoes, advised to avoid long distance walking. He was referred to the plastic surgery for surgical excision. So they did total excision of the tumor till the subcutaneous fat with 1 centimeter margin. Skin graft was taken from the same leg. And the graft was applied and fixed with the staples. So this kind of tumor is counted as an extremely rare benign adnexal tumor. The etiology is not yet understood, either neoplastic, hyperplastic, or hamartamos. For some reason, it favors the extremities, especially the legs. Malignant transformation has been reported, unfortunately. Treatment includes surgical excision, laser therapy, oral retinoids, and topicals as well. So there are 5 types based on the clinical manifestation and Starring's classification. So type 1, it's multiple with ectodermal dysplasia that I will talk about shortly. Type 2, it is multiple but without other cutaneous feature. Type 3, which is the most rare considered, it's the nevoid type. Type 4, which is the most common, as in our case, the solitary form. Type 5, which is the reactive, it can be linked with inflammatory dermatosis, with infections like HIV, neoplasms like BCC and SCC. So as we mentioned, the type 1, it's related with 2 syndrome, the Stokes-Jones-Passard syndrome, which is autosomal recessive, and there will be mutation in WNT10A gene. The Closton syndrome, it is autosomal dominant, where there will be mutation in gap junction beta 6. Both of them have nail, hair, and skin manifestation as well. So as we mentioned, the diagnosis is completely histologic. As in our case, there will be proliferation of thin anastomosing epithelial cords projecting from epidermis deep to the dermis. The cords are consisting of cuboidal cells that are smaller, usually smaller than the neighboring keratinocytes. The cords contain ductal structure and they surround a fibrovascular tumor. So we looked into the literature. We saw to track management experiences from different case reports. As you can see here, the first figure, multiple eccrine syringe fibroadenoma on the right foot dorsum. It was managed by incisional biopsy, followed by serial shaving of the lesion until its complete excision. Another figure, the solitary lesion on the scalp, excisional biopsy was done. And then you can see here also a solitary eccrine syringe fibroadenoma on the right malleolus, which was excised surgically, followed by reconstruction with a flap. And the last one, it is a very interesting case of reactive eccrine syringe fibroadenoma, which was managed with topical clobetasol. Our take clinic notes for today is we need to be sure to take more than one biopsy from different lesion. We should not underestimate typical lesions. A thorough clinical examination is mandatory to rule out other syndromes, and detailed history can eliminate other differentials. These are my references. Thank you so much for listening.
Now you can take a breath. You went so quickly.
Yes.
So I have one question.
Yeah.
Initially, you've taken 2 skin biopsies.
Yes.
Why? What did you do with them?
So because the lesions, as I mentioned, it was from 3 years. So we wanted to exclude, and the lesion was relatively big. So we wanted to exclude, for example, SCC from other lesion. This was our main thing. We want to exclude tumors.
Okay,
That's
only
why-
for the tumors, but you had a list of differentials which had TB, fungal infection. So what did you do with the 2 biopsies if you had these 2 differentials as well? Tuberculosis verrucosus as well as chromoblastomycosis. If that was the,
Yeah. So
in your differentials, what did you do with the biopsies?
exactly. So since we diagnosed it with eccrine syringe fibroadenoma.
That was in the second 2 biopsies, not in the first biopsy.
Exactly.
So what was done with the first 2 biopsies?
Yeah, as I told you, the lesion was big.
Yeah.
So our main thing is to exclude neoplasms. That's why we took 2 biopsies.
So my question is, did you send the biopsies for culture of these organisms? If you had that in your differential diagnosis?
Yes, it was sent.
They were sent?
Yeah.
What was the result? Because your first biopsy, the result was of a wart.
Yeah.
Okay. And what about the culture reports?
Yeah, the culture didn't reveal any organism. So as I mentioned, we started cryotherapy sessions. When the patient did not respond with the cryotherapy sessions, then we decided to take 2 other biopsies.
Thank you.
Thank you so much.
Thank you. Very good case. Thank you. Okay, I would like to invite Dr. INT'L Jouaid, syringoadenoma papilliferum on the chest, a case report.
Good evening, everybody. My name is Dr. INT'L Jouaid. I'm a resident in Rashid Hospital, R1. So I'll start with my case. It's a syringiocyst adenoma papilliform on the chest. Okay. So regarding the patient's demographic, he's an 11-year-old Emirati boy. Okay. He came to us with a slowly growing lesion on the chest, first noticed at birth. The lesion over time it increased in size and it darkened. Okay, and it was associated recently with pruritus, not from the beginning. It is not associated with any bleeding, any discharge or anything. Okay, for the patient history, he has no known comorbidities. Regarding the birth, he is born to non-conciduous parents with uneventful birth, full term, binormal vaginal delivery. He is up to date with his immunization. There is no developmental delay. Okay. And on physical examination, we can see that the lesion is on the anterior chest wall, showing well-circumscribed groups, papules measuring from 3 to 4 millimeter, ranging in color from skin color to pink violaceous. We can see in these papules they have like dots of white debris with the central dots, which will be more obvious on dermoscopy. We actually examined this patient with the Dr. Enzo himself, in which he took the picture of this dermoscopy. We can see concentric papillomatous structure showing central round brown area of ulceration, pointed with the long arrow, surrounded by a white halo, which is pointed by the arrowhead, okay, with a white to purple pink background. For our differentials, dermatofibroma protuberans, lymphangioma circumscriptum, as well as adnexal tumors and nevus sebaceous. Okay, so for the investigations, we did punch biopsy, which shows dome-shaped cystic invaginations, which was lined by eccrine epithelium filled with amorphous debris. Okay, some focal areas of papillary epithelium hyperplasia were observed protruding into the cystic spaces, confirming the diagnosis of syringiocyst adenoma papillariform with no signs of malignancy. Okay, so it confirmed our diagnosis. So the syringiocyst adenoma papillariform is a rare adnexal tumor of epicrine or ecrine differentiation. Approximately, there is 730 cases have been reported in the literature, so it is very rare. It often presents at birth or during puberty. It usually develops in the context of nevus sebaceous or de novo in our case. And the most areas being involved is the chest, as the head and neck. In our case, it was affected the chest. Okay, so as we can tell, it is very non-specific. The lesion is like skin-colored to pink papule. There are 3 clinical types that have been described, which is the plaque, as well as the linear and the solitary. The plaque is an alopecia plaque, which is on the scalp, and the linear is like the multiple reddish firm papules or umbilicated nodules, 1 to 10 millimeters, and the solitary nodule is domed pediculated nodules. I tried to look in the literature for any pictures to put them, but I could not really find. So these are the clinical types that have been described. And there's immunohistochemical staining done, which can help us differentiate the type of the origin of the tumor. But in our case, it was not done. We only did the biopsy, which confirmed the diagnosis. So the overall risk of malignant transformation of scalp is very low. The study is indicating that less than 1% of the cases progress to malignancy. However, long-standing lesions of these show suspicious features, so we would go for prophylactic surgical excision. Our patient has actually booked for surgical excision with Dr. Tariq, but his surgery still haven't been done yet. Okay. So my take-home message is like adnexal tumors are very diverse. So they're part of the sebaceous sweat glands in the hair follicles. So they have like as dermatologists, it's very difficult to diagnose them. First, because they are rare. Secondly, because they share similar features and they have non-specific presentations. And as I said before, histological diversity, they have overlapping feature, and they need histological evaluation. And sometimes the immunohistochemical staining could be helpful in this case. That's it for my presentation. Thank you, everybody. Thank you.
Thank you. What was the location on the chest? Was it close to the breast or axilla?
No, it was on the anterior chest, below the clavicle.
Okay, because they're usually associated with which glands?
With what?
With which glands? Apocrine or eccrine glands?
Eccrine. In our case, it was eccrine.
Okay.
May I ask you?
Yeah.
Congratulations. It was a very nice case that we saw together. Can you tell us we saw that the typical dermoscopic features were these polygonal erosions with crusting and the white halo. Can you tell us the histopathological background of these 2 findings?
I couldn't understand the question.
Okay. Because we have these cystic spaces, okay, with crusting, that is the erosion with crusting, and then we have the proliferation of the cells at the periphery, no? And we have this halo.
Yeah. Okay, any more questions?
Thank you. Our next speaker, Dr. Mayar El-Bahrani, bullous pyoderma gangrenosum associated with antiphospholipid syndrome, case report and literature review.
Good evening to you all. My name is Mayar El-Bahrani. I'm a first-year dermatology resident at the Oman Medical Specialty Board. And today I'm here to share with you my recent publication, which is a case report under the name Bullous pyoderma gangrenosum associated with antiphospholipid syndrome. So this is a list of my fellow authors, and I'm gonna jump straight into it. Firstly, I'd like to share the background and the essence of our case report. As you might know, antiphospholipid syndrome has long been known for its cutaneous manifestations. Among those manifestations are the chronic lower limb ulcers that might go under the name cutaneous necrosis. There has been debate in the literature whether those ulcers might resemble pyoderma gangrenosum, especially that pyoderma gangrenosum might occur in the context of autoimmune and inflammatory conditions. So in the discussion part, we are trying to explore an association between those two conditions. So our case is a 49-year-old lady. She's known to have antiphospholipid syndrome, and her disorder is complicated by iron deficiency anemia. In February 2022, she presents to the emergency department with low hemoglobin requiring transfusion. Now, upon cannulation and for the first time, she develops a local reaction. This reaction hindered her transfusion process. Those are images of her early lesions. As you can see on the left side, the area of cannulation or the area of pathergy has progressed to develop a superficial bulla with surrounding erythema. And on the left-hand side, this is the same lesion a week apart, and you can see that the bulla has collapsed, eroded, and formed a deep ulcer. Initially, the diagnosis was ambiguous, and unfortunately, she was initially managed with surgical intervention. So she underwent incision and drainage, she underwent debridement of some areas of her lesions, which worsened her condition. And by the time the dermatology and rheumatology teams were involved, she had extensive lesions in all her forelimbs. A punch biopsy was taken, and it confirmed the diagnosis of pyoderma gangrenosum. And as you can see, her histology slides on the top side, it shows neutrophilic dermatosis with no vasculitic changes, and that's a defining feature of pyoderma gangrenosum. On the bottom side is another histology slide of the epidermis, and it shows an intra-epidermal pustular bulla within an acanthotic epidermis. Now, in terms of management, this patient has been managed for many months, and her case was deemed refractory. Initially, she was treated with prednisone and cyclosporine as a steroid-sparing agent, and her response was suboptimal. So it was the decision was made to consider biologic agents. The first biologic agent to be considered was infliximab, but the patient refused it completely because it required an IV access. So the patient was then started on adalimumab, and approximately she stayed on adalimumab for 2 months, for which she responded, but she did not clear all her lesions. So as a multidisciplinary team, it was decided to upgrade her biologic agent to ustekinumab. And this decision was based on the recent literature of and evidence that ustekinumab works well for refractory cases of pyoderma gangrenosum. So you can see here that she has a refractory lesion on her lower limb before the use of ustekinumab, and this is after the use of ustekinumab by a couple of months. Now, in our discussion part, we do mention that we use the Delphi consensus criteria to diagnose our patient, and it basically consists of a single major criterion and 8 minor criteria. And it actually yields good sensitivity and specificity, especially if you have more than 4 minor criterions. As I mentioned earlier, our case triggered us to look for an association between antiphospholipid syndrome and pyoderma gangrenosum. There has been very little reports and studies done around this link or this association, but the ones that actually mention this link are very interesting. One study that I would like to mention is where they brought a group of patients with antiphospholipid syndrome that had chronic lower limb ulcers, and they closely studied those ulcers, and they found that actually all of them resemble pyoderma gangrenosum clinically. What's more interesting is that they also sent pathological testing for those ulcers, and all of them had features of pyoderma gangrenosum. In addition to that, all of those patients were treated with the first-line management of pyoderma gangrenosum, which is steroid and steroid-sparing agent, and all of them had remission. So in conclusion, we might say that pyoderma gangrenosum might be overlooked as a cutaneous manifestation in antiphospholipid syndrome, and more research needs to be done around this issue to confirm the association or the link. Those are my references. Thank you for listening.
Thank you. Any questions?
That was very interesting with so many neutrophils floating around in this inflammation and the immune background to the inflammation. Are you aware of any other biologic being considered in pyoderma gangrenosum?
Any biologics? Sorry?
Any other newer biologic being considered in pyoderma
gangrenosum? I think anakinra has been described in literature, and we actually used it for our patient for a while, but with no added benefit, so we stopped it. Other than ustekinumab, I don't want to make things up, but I think secukinumab has been used. Infliximab I already mentioned. Yeah, that's about the ones I know.
Good, good. You have answered well. Just for information, spesolimab, IL-36 blocker, has been found to be very useful in pyoderma gangrenosum. In fact, recently there are a lot of publications on this.
Right, okay. Yeah. Thank you, doctor.
Thank you.
Did you investigate the patient any further for any underlying causes of the PG?
Yes,
apart from the APLA syndrome?
So we know that pyoderma gangrenosum has a strong association with many disorders, autoimmune, inflammatory, and hematologic disorders. And with bullous pyoderma gangrenosum, it's usually with hematologic disorders. And we actually decided to go for a bone marrow aspirate, but the patient strongly refused it because the first attempt, it caused an extensive pathologic reaction, and she refused any further attempts. But we continued to follow up her with the routine bloods. That's what we can do for her. Yeah.
Thank you. Our next speaker is Dr. Noor El-Aufi, disclosing a rare occurrence, pseudoxanthomatous mastocytosis.
Hello everyone, my name is Noor El-Aufi and I am a dermatology resident from Oman. So today I will disclose a case of pseudoxanthomatous mastocytosis. This is the outline. We will go through the history, examination, differential diagnosis, plan, histopathology results, literature review, conclusion, and take-home message. So I'm presenting a case of 6-year-old Omani girl who was previously healthy. She presented with history of generalized itching all over the body, and she was having multiple raised yellowish lesions over the neck and anterior trunk since few months. Initially, lesions were flat, but then they became raised and they increased in number. There were no records of systemic symptoms like flushing, palpitation, dizziness, etc. Family history was positive for primary hypercholesteremia. On examination, general examination was unremarkable. However, she was having multiple firm yellowish round to oval papules and plaques over the neck, and there were also multiple yellowish to pinkish macules and plaques over the anterior trunk. However, Darier's sign was negative at that time. A list of differential diagnoses came to our mind, including xanthoma, juvenile xanthogranuloma, mastocytosis, pseudoxanthoma elasticum, Langerhans cell histocytosis, and other non-Langerhans cell histocytosis. So initially, we sent for her basic blood investigations, including CBC, lipid profile, liver, and renal function test, in which all came normal. We obtained 3 mm skin bunch biopsy. She was managed initially with oral antihistamine and mild topical corticosteroid cream. So after 3 weeks almost, biopsy resulted as dermal lesion composed of sheets of mast cells. Special stains were done, including Giemsa stain and Tulidin blue stain, in which they were positive. Immunohistochemistry CD117 was also positive. So based on the clinical presentation of the patients along with the histopathological results, we conclude that it is a case of diffuse cutaneous mastocytosis with xanthelasmoid variant. The parents received counseling about the condition of the child and the expected course of the disease and prognosis. Child symptoms were effectively managed using oral antihistamine and mild topical corticosteroid cream. And she was under regular surveillance, and within 4 months, all lesions disappeared with no new outbreaks. And there was also any systemic signs. So based on our literature, pseudoxanthomatous or xanthelasmoid mastocytosis is an extremely rare type of diffuse cutaneous mastocytosis. It appears as flat, yellowish papules and nodules of varying sizes that resemble xanthomas or lesions of pseudoxanthoma elastica. The specific frequency is unknown, but it is estimated to fluctuate between 8 to 25%. It may appear in specific areas of the body, or it might be spread out. And it may not exhibit the typical positive Darrier sign, as in our case. There were limited number of cases reported worldwide. Most of the cases we found were from India. No cases were reported from the Middle East. Sinha et al. In 2019 reported a case of 11-year-old boy who presented with 2 years history of widespread, itchy, yellowish to skin-colored eruption on the trunk and extremities. Darrier sign in his case also was negative, as in our case, and skin biopsy confirmed the diagnosis of mastocytosis. Niwan et al. In 2020 reported also a case of 10-year-old female. She presented with 6-month history of asymptomatic, firm, yellowish papules and nodules measuring few millimeters to 1 to 2 centimeters were present in labia majora. Also, Darrier sign in her condition was negative, and skin biopsy revealed the presence of mastocytosis. So, in conclusion, pseudoxanthomatous mastocytosis is a rare form of cutaneous mastocytosis. It is characterized by yellowish xanthomatous lesions, often mistaken for other dermatological conditions. Accurate diagnosis relies on clinical evaluation, histopathological analysis, and supportive laboratory findings to confirm the proliferation of mast cells. So to take home messages, it is important to consider pseudoxanthomatous mastocytosis in the differential diagnosis of any atypical cutaneous presentations. The timely recognition and differentiation are essential for proper management and assessing systemic involvement. These are my references. Thank you for your kind attention.
Thank you. In pediatric patients, if you want to rule out Langerhans histiocytosis, what stain would you do? So Langerhans cells, I mean, you did 3 stains for mast cells.
Yeah.
The CD117, the Giemsa, and Tolidin blue. So so this is confirmatory. But if you want to rule out Langerhans cells,
we can do the Langerine.
Yes, Langerine with the Langerine is.
We can also send, I think, a blood test, which is tryptase, which is usually high in mastocytosis.
No,
sometimes, yeah.
Langerine is correct, and we also do CD1A and S100, but Langerine is correct. Thank you. Any other questions from the jury?
Just a simple question. You mentioned that Darrier sign is so often negative. Do you have an explanation?
Why in pseudoxanthomatous is often negative? No, I didn't find any explanation.
Yeah, maybe the number of mastocytes in the lesion. The number of mastocytes in the lesions. It's less than the typical mastocytosis because, for example, in adult patients, Darrier sign is rare because mastocytes in the lesions are less than the pediatric forms. Maybe the number of mastocytes in the lesions are less.
I didn't came like an information in my literature like this, but maybe it's worth to read about it more.
Okay.
Although in this case, there was a lot of mast cells, so the
Yeah, it
derriere
was like
sign
a
should have been
sheets of
positive.
mast
Yeah, maybe the dark skin, maybe it wasn't very clear. Then
Maybe because the type of the skin tone.
Thank you very much.
Thank you.
Our next speaker is Dr. Sheikha El Haj.
Okay. Hello, everyone. I didn't want to reveal the diagnosis. I always like to start my presentation with a question. And today's question is, can dermatologists save lives? We'll answer the question at the end of the presentation. So our case is a 50-year-old female who presented due to on and off ulcers in her genitalia for about 1 year. On physical examination, we saw that there were draining sinuses and erosions. We diagnosed the patient with hidradenitis suppurativa, Hurley stage 3, and we started the patient on Humira injections. 5 months later, the patient still had persistent symptoms. In fact, her symptoms were getting even worse. Also, she reported that she's been losing weight. On physical examination, we saw multiple tender, hard plaques over the genitalia with surrounding erythema and fissures. And this is when we thought of what could be our differential diagnosis. So we thought of maybe it's hidradenitis suppurativa being resistant to treatment. Could be Crohn's disease, could be extramammary Paget's disease, could be a skin metastasis due to a cancer somewhere else, could be pemphigus vegetans, or genital sarcoidosis. Labs, nothing was significant except for the iron deficiency anemia she had. What we did next was a biopsy. So what we saw histologically, we saw abnormal cells infiltrating all over the epidermis, dermis up until the subcutaneous tissue. On higher magnification, we saw these abnormal cells. So these cells contain foamy cytoplasm with a nucleus pushed to the periphery. These resemble signet cells. They're called signet cells because they resemble a signet ring. The signet cells here are surrounding the neuron, as we can see. And of course, we did some immunohistochemistry. Pankeratin was positive, CDX2 was positive, GATA3 and CK7 were negative. This is just a summary of what the immunohistochemistry that were positive and negative, and we diagnosed the patient with signet cell carcinoma. Now, when we diagnose the patient with signet cell carcinoma, signet cells are not usually seen in the skin. And therefore, we thought, okay, there could be a primary source of the signet cell. So what is the most common site of signet cell carcinoma? It is the gastrointestinal tract. And therefore, we referred the patient to gastroenterology and to oncology for further management. Now, my question is there a link between hidradenitis suppurativa and signet cell carcinoma? I tried to search in the literature. Basically, there's no link. However, there was a beautiful study done to investigate the link between hidradenitis suppurativa and squamous cell carcinoma. They found 74 patients that have both hidradenitis suppurativa and squamous cell carcinoma. So they wanted to know, is one of them causing the other? Hidradenitis suppurativa causes chronic inflammation, and once you have chronic inflammation, you have immune tolerance, you have a place where malignant cells can proliferate. And therefore, whenever we have chronic inflammation, we have angiogenesis, and we have an environment that can grow the malignant cells, basically. And of course, the immune tolerance, and therefore the host will not be able to attack these proliferating cells. Another thing is that the patient had iron deficiency anemia. This is just a small explanation why the patient could be having a colon cancer. When we referred the patient to gastroenterology, it turns out that the patient has signet cell carcinoma of the colon metastasized into the vulva. There are 3 take-home messages that I would like everyone to remember before the end of my conversation. 1, chronic inflammation can provide a site for metastatic cells to grow and proliferate.
Number two is that even if it was not caused by HS, us as dermatologists, we should always keep in mind that patients can present with two different dermatological conditions at the same time. And therefore, we should treat each one individually and not neglect the other. The third important point is that dermatologists can take the lead in diagnosing life-threatening conditions. So, going back to my first question, can dermatologists save lives? The answer is yes. And in fact, it's not just in this case, it's not just cases of metastatic cancers. There are various conditions in which a dermatologist can improve mortality in patients. These are my references, and thank you.
Thank you. Any questions from the...
Yeah, you mentioned the possible link between hidradenitis suppurativa and squamous cell carcinoma.
Yes.
Did you find any study in the literature showing the risk of developing SCC in patients treated with anti-TNF-alpha compared to patients treated with antibiotics? Because we know that in psoriasis there is no risk, but in hidradenitis suppurativa there is already the risk of chronic inflammation, local chronic inflammation. So is there any
so basically, when I searched the literature, I couldn't find something related to that, but maybe if I could search more, I would find. But so far, this is the only study that really proved the correlation between the two. Nothing about the biologics or any treatment
So there
given.
is no study on the risk of developing SCC in
Based
HS
on what,
patients?
based on what I've seen, what I've searched, no.
Nice. Should be done.
What was the site of the biopsy?
Over here, I'll show you exactly. On the labia majora, we took 3 biopsies, actually. One of them is shown here with a stitch, as you can see.
So what made you choose that site?
Sorry?
What made you choose that site for the biopsy? Because basically your primary diagnosis was HS, isn't it?
Yes, what made us choose?
The site for the biopsy.
So basically, she was just presenting with erosions on the genitalia. So the most recent erythema we saw was in that site. So the most new lesion was in that particular site.
Thank you. I agree with you not to put the diagnosis in the title. So it's always good to keep the audience, on edge, trying to figure out what the case is. So that's very nice. Thank you.
Thank you.
Okay, our next speaker is Dr. Farah El-Mughira, lobular capillary hemangioma post-chemotherapy for T-cell leukemia treated with an antibiotic, a case report.
Hello everyone, I am Farah Al-Mughira, dermatology resident, PGY2 from Riyadh, currently working in Prince Sultan Military Medical City. So today I'm going to present an interesting case about lobular capillary hemangioma post-chemotherapy for T-cell leukemia treated with an antibiotic. So the elements of my presentation will be a history of a presenting complaint, findings on physical examination will be demonstrated, and investigations, and finally outcome and discussion. So our patient is a 32-year-old patient known to have acute lymphoblastic leukemia treated successfully with chemotherapy. He was maintained then on 6-mercaptopurine and methotrexate, presented to our dermatology clinic with 1-month history of painful, rapidly growing ulcerated nodules over the right hand palm and also the middle finger. So both of these skin lesions were noted to appear approximately 3 months after the initiation of the maintenance chemotherapy. The palmar skin lesion was actually noted to appear first. A week later, a similar lesion grew distally on the middle finger. So patient does not recall a history of a trauma, burn, or insect bites. And regarding medication history, he denied taking any oral retinoids apart from the maintenance chemotherapy he was already on. He did not take any medications. So our differential diagnosis at this point is squamous cell carcinoma, a bacillary angiomatosis, and hypertrophic granulation tissue induced by trauma. So physical examination, as you can see here, revealed two crusted nodules, one appearing on the palmar aspect base, the digit between the digits, the second and the third digit, and the other one occurring alongside the distal phalanx of the third digit. So the proximal lesion measured 2.5 in 1.5 centimeter, while the distal one measured 2.5 and 3.5 centimeters. So what we did for this patient is a shave biopsy followed by cauterization of the floor was performed for the proximal ulcerated nodule, and the specimen was sent for histologic examination, bacterial culture, and mycobacterial culture, and also fungal culture. So a week later, following this patient, we noticed that the proximal nodule was noted to regrow again, while the distal one continued enlarging. So a 2 millimeter punch biopsy was taken from the distal lesion and then was sent to undergo similar sets of examination. So the results of the histologic examination was consistent with the finding in the palmar skin lesion, shave biopsy, and it revealed inflamed biogenic granuloma. The tissue culture of both specimens, the proximal and the distal one, tested positive for Pseudomonas aeruginosa growth, while fungal and TB culture were negative. So as you can see here, the two histologic slides, you can see in the left side, medium power revealing lobules of blood vessels with an overlying acanthotic epidermis. On the other slide, you can see high power exhibiting capillary-sized blood vessels lined by benign endothelial cells. So based on the positive Pseudomonas aeruginosa culture, we started this patient on ciprofloxacin 500 milligram twice daily for 2 weeks. Upon following this patient up on the 10th day of receiving antibiotic course, as you can see in the picture, there is complete tumor resolution with no residual scarring and no recurrence as well. And this was noted on the 10th day of antibiotic course. So this slide summarizes a timeline of events. So on the 30th of August was the start of the maintenance chemotherapy. 3 months approximately after the initiation of the maintenance chemotherapy, patient first clinical presentation was the development of the two ulcerated nodules. And then the diagnosis of biogenic granuloma was established. After that, tissue cultures tested positive for Pseudomonas aeruginosa. So the day after, patient was started on ciprofloxacin 500 milligram twice daily for 2 weeks. On the 10th day antibiotic course, complete tumor resolution was noticed. So as we all know, surgical excision is the most frequently used treatment for biogenic granuloma. The aim of starting the patient on antibiotic treatment was to manage any concurrent illnesses prior to treating the primary lesion. But what happened here is a patient was eventually, the primary lesion was treated and cured effectively using only an antibiotic with a short course. So we also noticed that the cosmetic outcome of our conservative treatment was superior to the surgical management, which usually leaves a residual scar. Upon following patient up, even patient dermatoglyphia fingerprints was noted to be intact. So given the tissue culture results in our study and other formally reported cases, we hypothesized that gram-negative infection may be a trigger inducing the angiomatous proliferation. We also theorized that if this infectious trigger were to be removed, chances of curing biogenic granuloma can be achieved. So actually there is one case in the literature which described children with multiple biogenic granuloma obtained after scalded skin injury, burn injury. They were treated conservatively using 1% povidone iodine and antibiotic. In tissue culture, they also isolated the gram-negative and the gram-positive bacteria. They were treated conservatively and they were followed over a period of 2 months to approximately 6 years. And it was noted that there is tumor regression but not complete resolution as noticed in our case. Thank you so much.
Any questions from your end? I mean, usually pyogenic granuloma, they don't submit for culture, so I'm wondering if the other pyogenic granulomas we get all the time are really of infectious origin.
We sent we did not at that time expect any infectious process, but it was a routine to send the specimen for all bacterial, culture, and TB. Patient tested positive, although there was no specific indication clinically to.
Well, he's immunocompromised, right?
Yes, he's immunocompromised.
Yes, so this would be the right management, yes, to send.
Yes, and as I've mentioned, we also anticipated, since patient is immunocompromised, bacillary angiomatosis. We asked about animal contact, but he denied, but yet we took the culture.
I'm glad you mentioned bacillary angiomatosis. Thank you.
Thank you.
Our next
Did you
speaker.
perform any special stains considering the fact that he had leukemia?
Sorry, I can't hear
Did you perform any special stains on the biopsy since he already had an adult T-cell leukemia?
No, not really. Only regular H&E. Not really.
Thank you. Our next speaker is Dr. Walid Ilgohaythat. Comparative efficiency of oral minoxidil and topical minoxidil in treating androgenetic alopecia, a systemic review and meta-analysis.
Hi, good evening, everyone. First of all, I want to thank you for this great event. Actually, it's an honor to be a part of this event. My name is Walid Ghaythat at Tajmid Dermatology. So the title of this topic, it is the comparative efficacy of oral minoxidil and topical minoxidil in treating androgenetic alopecia, a systemic review and meta-analysis. So as an introduction, androgenetic alopecia is the most common disorder of hair loss in men and women that can severely interfere with quality of life, self-esteem, and also psychological well-being. Minoxidil is one of the drugs that are widely used and commercially as available as minoxidil. The systemic review with meta-analysis intend to compare the efficacy and safety of oral minoxidil and topical minoxidil in treatment of androgenetic alopecia. So the methodology, the systemic literature was conducted across 7 major databases, PubMed, Scopus, Web of Science, etc. After a close filtering, 4 articles has been chosen to be included of our meta-analysis that meets our inclusion criteria. So this is a premise chart, which is showing from the beginning of the screening, it was 213, and by the end we choose, as I mentioned before, 4 articles. So the results, the efficacy of oral minoxidil compared to the typical minoxidil, this meta-analysis result didn't express any statistical significant superiority of oral minoxidil compared to the typical minoxidil with odds ratio 2.23. Since the studies are relatively homogeneous and overall the test was not significant, suggests that the outcome effect of oral minoxidil for positive hair growth is not that better of typical minoxidil. But when you are speaking about the side effect, we divide into 3 categories: the hypertrichosis, pterygium flavium, and scalp pruritus. In hypertrichosis, also it wasn't significant with odd ratio 3.58, and also with pterygium flavium wasn't significant. And scalp pruritus also wasn't significant, but the cumulative analysis of all adverse effects showing it was significant, showing that oral minoxidil has side effects more compared to the typical minoxidil. So in conclusion, this review concluded that both oral and topical minoxidil are effective in promoting hair growth and androgenetic alopecia with different efficacy of anti-tolerability. The topical minoxidil demonstrated better improvement in hair density and fewer side effects compared to the oral minoxidil, but one of the articles mentioned that the oral minoxidil is better if we are treating the vertex with higher incidence of side effects such as hypertrichosis and headache. Thank you for the listening.
Were the androgenetic alopecia, any of them had biopsy confirmation?
You mean to diagnose it?
Yes.
Yeah, we use it. But this is meta-analysis. We just collect the articles that showing our objective is to compare the efficacy and side effects of oral minoxidil compared to topical minoxidil, not ACACIA report. So we didn't take biopsy.
So this is only literature review?
Yeah, systemic review and meta-analysis.
Okay, thank you.
You're welcome.
Something. Which concentration was the topical minoxidil?
What?
Which concentration? 2%, 5%?
We include both of them. We choose
you
for
include
articles,
both?
yeah, to 0.25 and 0.5.
Okay, because when we talk about 5%, okay, the efficacy is more or less the same as 1 milligram of oral minoxidil, but 2% is less effective. So, yeah, should be done a differentiation according to the concentration.
Thank you so much. Thank you.
Thank you. Our next speaker is Dr. Yusra El-Lamki. Is it a flare of von Zumbusch or sepsis?
Good evening, everyone. I'm Dr. Yusra from Sultanate of Oman. I'm glad to be here to present my case presentation, which is about, is it a flare of Zumbusch disease or sepsis? So this is my outline. So starting with the background about the disease, as you know, generalized pustular psoriasis or a von Zumbusch type is a rare autoinflammatory skin disease which is characterized by widespread eruption of sterile and neutrophilic pustules. GBP is a heterogeneous disease which is in variable manifestations, so patients may experience different flares, periods of clear skin as well, persist with flares of increasing severity. So those flares can be triggered by several factors like medication, pregnancy, and infections, and can be associated with systemic symptoms and markers of high inflammatory markers as well. So if left untreated, systemic inflammation associated with GBP can be complicated with sepsis and multi-organ failure. So as a rare disease, we don't have that much clinical studies and standardized management approaches, so there is a paucity of knowledge regarding the GBP. So in our case, we have a 36-year-old male with no previous medical background. He is not taking any medication. He presents with few days history of sudden onset generalized skin lesion and fever. In examination, he was febrile, but other vitals were stable. He has generalized erythema with tiny pustules all over his body, like covered around 90% of the body surface area. Otherwise, no mucosal involvement and no nail changes, no lymphadenopathy, and no organomegaly as well. So those pictures shows like those studied pustules all over his skin. So our differential diagnosis were pustular psoriasis, acute generalized exanthematous pustulosis, also there is no clear drug intake, and subcorneal pustular dermatosis, linear IgA bullous dermatosis. In investigation, we did a complete blood workup, including CBC, LFT, CRB, and ESR. All were normal except high CRB plus 300 and mild elevation in neutrophilic count. Also, we took a punch biopsy for skin biopsy was taken from pustules for H&E, also a peri-lesional skin for immunofluorescence. Here, as you can see, the biopsy showed epidermal spongiosis with dense neutrophilic infiltrate with subcorneal cleft containing also neutrophils. For the immunofluorescence study, the C3, IgM, IgA, and IgG were all negative. So based on our clinical picture and finding, diagnosis of GBP was established. So regarding the treatment, we start to give the patient oral prednisolone, 1 milligram per kg, and he shows some mild improvement, but then we shift, with those flaring, we try to shift to oral cyclosporine, 4 milligram per kg, and he showed a significant improvement compared to oral prednisolone. And this picture, before and after starting cyclosporine, you can see the dramatic change. Then after a few weeks, despite his being on the same dose of cyclosporine, he was admitted other 4 times with sepsis, fever, symptoms of septic shock, like he was hypotensive, generalized erythema. For the first 3 admission only, blood culture was positive for MRSA. Otherwise, the 3 times were negative. And there was a debate between us, dermatology and medicine, whether to start the patient on IV antibiotics to treat sepsis or prednisolone and cyclosporine for rash. At the beginning, they start on tazocine, then they upgrade to meropenem with no clear improvement in the patient clinical. But since we start on cyclosporine, he improved. Those pictures shows the flare-ups while the patient on cyclosporine. You can see there is difference from the beginning. So then the patient was finally, we start him on anti-TNF, etanercept, based on our available anti-TNF at that time. And till now, he is taking anti-TNF. And he showed a dramatic improvement from the first dose within the 3 days only. So at conclusion, GBB clinical course is highly variable and it's generally unstable. And characteristic of GBB flare consists of rapidly disseminating erythema with those pustules and crusts. And flares are associated with systemic symptoms, so there is a highly need for multidisciplinary team approach. So far, there has been a lack of international consensus on the clinical course of treatment, objectives of GBB, with no established guideline to guide us how to treat the flares of GBB. So overall, GBB is a serious and life-threatening disease, and further studies needed to clearly define the flare. That's all my presentation. Thank you.
Did you start the patient on the anti-TNF like when the blood culture was positive for MRSA?
No. When the culture was positive, he was under medicine, so they start him on IV antibiotic.
Okay.
This one only the first visit was positive, then he admitted 3 times more were negative, so there is no point to start IV antibiotics. So at that time, we start to give oral prednisolone, then cyclosporine, then anti-TNF.
Okay.
Yeah, it was an interesting case. So you made a diagnosis of GPP in the first admission itself, is it, based on the clinical picture and biopsy?
Yeah, yes.
How would you differentiate GPP from AGEP in a biopsy?
From what?
From acute generalized exanthematous pustulosis. I can understand when he had multiple relapses, that multiple relapses are possibly more in favor of a GPP. But you made the diagnosis in the very first attempt, isn't it? So how would you how do you differentiate in a biopsy a difference between a GPP and an acute generalized exanthematous pustulosis? I think Dr. Reem might tell us even better.
There's one cell that can tell you that this is drug-related and it's not pustular psoriasis. What is this cell?
Neutrophils, you mean? Type of cells?
Eosinophils? What did you say?
You mean the type of cells?
No, the one with a lot of granules.
I have no clue.
Eosinophils. So eosinophils would point towards drug or AGEP. Yes.
Okay.
Yes.
Thank you.
Good case, thank you.
Good case, good.
Okay, our next and last speaker is Dr. Zainab El-Darwish, the role of tumor necrosis factor alpha in the management of a serious dermatological emergency, a case series. Welcome, Dr. Zainab.
Assalamu alaikum. So, good evening. My name is Zainab El-Darwish, one of the dermatology residents in Rashid Hospital. So today I would like to present to you the role of TNF-alpha in 3 life-threatening cases. So starting with the first case, a 59 years old Filipino lady presented with a fever, flu-like symptoms, and a painful rash that started 7 days ago. The patient had difficulty also opening her eyes. She was using allopurinol due to her hyperuricemia for about 3 weeks back. Aside from that, she was healthy. On examination, as you can see her face, trunk, extremities, as well as the hands and the feet. So on general inspection, the patient was alert, a bit distressed and febrile. On skin examination, there was multiple erythematous dusky macules that were coalescing into patches with all over the body. 3 mucosal areas was also affected, the oral, ocular, and genitalia. So BSA, it was more than 10%. Diagnosis of toxic epidermal necrolysis, so we diagnosed her as toxic epidermal necrolysis with a score 10 of 3. Moving to the next case, a 48-year-old Indian male, also presented with a painful rash as well as upper respiratory tract infection symptoms. He was taking IV ceftriaxone and paracetamol from private. He was known to be diabetic on oral medication for about 3 years back. On also examination, as you can see, the BSA was involved more than 10%. 3 also mucosal areas was affected. Toxic epidermal necrolysis was diagnosed, but score 10 of 2. Lastly, which is a pediatric case, 9 years old Indian male, presented with also flu symptoms and a painful rash since about 10 days after starting which is antibiotic, which is Augmentin. So he was also using which is other medications such as paracetamol and levocetirizine. Aside from that, he was healthy. On examination, as you can see, BSA was involved more than 10%, and 2 mucosal areas was affected, which is the oral and the genital area. Toxic epidermal necrolysis was diagnosed with a score 10 of 3. So according to our management approach, MDT was involved. So the first step that we have initiated was stopping the drug, the culprit drug mainly, multidisciplinary supportive management in the brain unit, which is really important, and also we start him on IV hydrocortisone 100 milligrams TDS as per the local guidelines. So during follow-up, do you think that these patients have, or these lesions have resolved? Unfortunately, these lesions were progressively getting worse, so we started there on INT'L, which is an etanercept. So for the first 2 cases, since they're elderly, we started on 50 milligrams subcutaneously. For the pediatric case, we started on 25 milligrams. Oh, sorry. So as you can see, that the lesions, they were resolved after approximately 1 week, so full resolution, full epithelialization, and without complications, which is mainly sepsis. So moving on to the discussion. So just general overview about toxic epidermal necrolysis and Stevens-Johnson syndrome. It's a life-threatening skin condition. Mainly it's affecting, which is the epidermis, which is extensive detachment as well as involvement in the mucosal membrane. Mainly it is caused by drugs. There is also genetic association with HLA-B that increase the risk of having this disease. And through the pathogenesis, it's really complex for having the pathogenesis is really complex. But I'll point out mainly on the role of TNF-alpha. So CD8, it produces many, it releases many cytokines. One of them is TNF-alpha. TNF-alpha, it causes, which is the keratin site apoptosis. Aside from that, it also increases the release of the granulosin, as well as expression of the Fas ligand, also causing apoptosis. So generally speaking, there is no any universal guidelines for treating these patients. But since we know the pathogenesis, we can halt the disease progression. That's why we are using the TNF-alpha inhibitor in these cases. I would like to support that with the research, a randomized control trial. It is open-blinded of using, which is the etanercept as a monotherapy. So it's mainly involved, they involved 96 patients. Half of them, they were using etanercept, half of them, which is corticosteroids. And the results was amazing. So mainly they were measuring 4 points: the mortality rate, the adverse events, the skin healing time, as well as the, mainly those. So also the cytokines. So as you can see that the etanercept is really effective in decreasing the TNF-alpha and also the granulosin and increasing the regulatory T cells. It decreased the time of the healing of the skin. So as you can see, 14 versus 19 for the corticosteroids, as well as decrease in the GI bleeding. I would like to support that with a retrospective studies also that was conducted with Au et al. Studies and John et al. Study. Both of them, they were using, which is combination with corticosteroids as well as the etanercept. And that was amazing results with decreasing the skin healing time, the GI bleeding, and the mortality rate. So a take-home message, Stevens-Johnson syndrome is really life-threatening case. You need to address it really quickly and stop the disease progression by stopping the drug. There is no really guideline, as I've mentioned, but we need more larger studies and double-blinded study to be more, let's say, to more be, how can I say, dependent or reliable. Thank you so much.
Thank you. Were any biopsies done on any of these cases to
Some of
confirm
them,
the diagnosis?
yeah, some of them, unfortunately not all of them.
Okay, what would you expect to see to diagnose what are the features? Do you know?
Yeah, so epidermal, which is apoptosis, mainly subepidermal blister also. What we can differentiate between this and the erythema multiforme is that there is no, which is the lymphocytic infiltrate, that like much or high lymphocytic infiltrate as in the toxic epidermal necrolysis.
Well, actually, you said correct. Any epidermal necrosis is diagnostic of, but histologically they all look the same.
Yeah.
It's a clinical diagnosis, erythema multiforme, toxic
Exactly,
epidermal.
and we need to act fast for these patients.
Yes, very good. Any other questions? Thank you very much. I would like to thank all the presenters for adhering to the time. So I think we'll give the jury 5 minutes to decide. So please stay. I would like to call all the presenters on stage so that we can take a group photo and then we will announce the winners. So please come. Have 14 presenters. Come so that we can take everybody. Missing two, I think. Two presenters. Anyone else? want to congratulate the R1. I think it's very good that you're able to come on stage and present the case. So congratulations for the young residents, all the residents, and the senior residents.
All of them were very confident, which was very, very nice, because level of confidence, there was hardly any difference.
Yes, very good. Yes, I agree. Yes. And you really all stuck to it. I was looking at the clock exactly. They would finish. One person didn't take a breath, just ran through it. And thank you for the audience for staying to the very end of the conference. Oh, come, wait. We'll have. خلاص, yes.
Mohammed, I ask your permission to announce. Okay, great. So you went very well, everyone. I have to say, but I don't understand your. Okay, so in the we have to announce first the third place. Okay, the third there is a shared position. Yeah, but I would like to also give credit to the third position, which is shared by Sheikha Al-Ktibi. Yeah, I don't know. Sorry for, congratulations. Then we have in the third place, Mayar Al-Barani. Okay, great. Second place, Shaika Alai. Okay. Yeah, and others. Second place, you come here. No. With the initiative. There you have to. So now it's time for the winner. The winner is Arim Alozani. Congratulations. The envelope. Okay. This is yours. Congratulations. Very well done. Great. Congratulations. You have very good residence. Every year. Yeah, let's show the